Hi, my name is John Lavasser, and I will be doing a presentation on increasing condom use. Today I'm going to be talking about increasing condom use during sexual encounters. We are going to talk about the risk associated with not using condoms, some risk factors for not using condoms, and then we are going to apply the constructs of the health belief model to condom use. As we apply these constructs, I will also talk about effective interventions for each construct, rather than having one separate section where we talk about interventions to change behavior. I will also be referencing some experiences I have had in talking to people about condom use. I am a Navy corpsman, and part of my job for the last 3 years has been talking to people who have had a positive STI or think they might have an STI, and discussing risky sexual health behaviors and talking about ways they could decrease the chances of acquiring HIV and STIs. Research shows that rates for STIs such as gonorrhea, chlamydia, and syphilis have been on the rise in the last decade. More people are living with HIV today than compared to 2010, according to the HIV surveillance report. This is true across all demographics such as age, ethnicity, and sexual orientation. This means there are more people who are sexually active and living with HIV. Sexually active adults who are younger than 23 years old are at increased risk for getting an STI or HIV. Increasing condom use for sexual encounters would reduce the risk of acquiring an STI or HIV. Next, we're going to talk about factors that influence condom use. Some factors that influence condom use. Research shows that not using a condom at first intercourse will lead to less chances of using a condom in subsequent sexual encounters. If you don't use it the first time, you have already started building a bad habit and are less likely to start using a condom. Research has also shown that college women and married men with multiple partners are less likely to use a condom. Some women may not feel confident in negotiating condom use, so they feel they have less control and are less likely to use a condom, while married men who have extramarital partners have likely developed the habit of not using a condom, and this behavior carries over to their other relationships. Next, we are going to talk about effects of not using a condom. Sexual intercourse without the use of a condom increases the risk of HIV, STIs, cervical and penile cancer, and unintended pregnancies. All these can be outcomes of not using a condom during intercourse. HIV and STIs are the most common cited risks. However, cancer from HPV can also be prevented from a combination of condoms and getting vaccinated for HPV. Some research has even shown that consistent condom use after an HPV infection can help increase the chances of clearing the infection by reducing re-exposure to the virus when compared to those who continue to have intercourse without using a condom. Next, we are going to look at the health belief model and its constructs and increasing condom use. Here we are going to apply the health belief model and its constructs to condom use. As I go along, I'm going to address effective ways to change behavior using that construct. Research has shown that there is a positive relationship between perceived susceptibility and condom use. Perceived susceptibility is that a person must believe they are susceptible to the negative effects associated with not using a condom. So they must believe that they are susceptible to HIV and STIs. Sometimes in the healthcare or public health profession, it is easy to take this as common knowledge. We must remember that not everyone has the same knowledge and understanding of HIV and STIs. I have met several people throughout the years who have a limited or misinformed understanding of STIs. This has ranged from fear and anxiety that they would never be cured of chlamydia, to thinking that they can tell if someone had an STI by the way their genitalia looked or smelled. Proper education is key to increasing perceived susceptibility with patients. Education is also key to helping patients to obtain a higher perceived severity. I have met people who have no concern over getting an STI because they are able to get treatment and take care of an infection relatively quickly and go back to their old behavior. In order to change an individual's perceived severity, we must properly educate on the long-term effects of STIs, the increased risk of cervical, penile, or anal cancer due to HPV, and the seriousness and possibility of HIV. Next, we're going to talk about perceived benefits and perceived barriers. Perceived benefits: individuals must believe condom use can reduce the risk. Research shows that there is a positive relationship between perceived benefits and condom use. Education on proper condom use is key for addressing this perception. I have had patients who stated they did use a condom during their sexual encounter and still got an STI. During our discussion, I have discovered that usually they did not use a condom properly. They had outer course and only used a condom once penetration began, or put a condom on after penetration occurred, most likely to prevent unintended pregnancies. Patients must be educated on proper condom use before contact with genitalia and the necessity to use condoms or other barrier methods for oral sex as well. Perceived barriers. A person must identify their personal barriers to condom use and work to reduce those barriers. Some perceived barriers to condom use may be statements such as, "They're too tight, it reduces the sensation," or "He or she looked clean, so I didn't think I had to use a condom." We can help to reduce perceived barriers by addressing each barrier specifically. For example, advising them that there are different size condoms, or that there are condoms that are designed to improve the sensation for both the patient and the partner. Or something like, you cannot tell if someone has an STI just by looking at them. Research has shown that reducing perceived barriers to condom use increases the likelihood of condom use. The last two constructs we're going to look at are cues to action and self-efficacy. Cues to action is a method to remind them of condom use. An individual must have a cue to remind them about using a condom. Asking patients how they feel about carrying a condom when they know they're going to be going out, drinking, or inviting someone over for Netflix and chill is beneficial in helping patients think of ways to remind themselves to use condoms. Some patients I have talked to have said that an anonymous or hookup partner would be their cue, but that they didn't plan on using condoms with their regular partner or partners. This is still good because any increase in condom use is beneficial. Individuals must believe in their ability to use a condom. This can be achieved through education or discussing condom negotiating skills. Research has shown that women who are confident in their ability to bring up condom use with their partners are more likely to use condoms. In addition, helping address self-defeating thoughts such as, if I put a condom on, my partner will think that I have something or that I don't trust them, may also help increase self-efficacy. These are the references for my presentation on increasing condom use. We can see that the best ways to address condom use is discussions and education on each particular belief a patient may have in regards to condom use. The last reference on this page is the article that discusses condoms increasing the chances of a woman clearing an HPV infection if they use condoms. It's a difficult but interesting read. Here are the rest of the references used in this presentation. And this concludes my presentation. Thank you for your time.